Okay, I hope my screen is visible to everyone.
Yes, sir. It's visible.
Okay, thank you much. So before we start, can we have a quick introduction from everyone, so that I can get to know about you, what level you are, what type of profession you are in. Meanwhile, I would like to thank Professor Manoj sir for the kind introduction and for being here for our talk. And for all the participants, thank you very much again for joining in this session. I hope that we'll have some very nice discussions here. Okay, so before we start, can you please introduce yourself just very quickly? Tell me about your profession, if that's okay by everyone.
Good evening, sir. This is Dr. Deepak, and I belong to physiotherapy department. And currently, I'm pursuing physiotherapy in the Department of Physiotherapy in SRM University, Chennai.
Okay, thank you very much. Nice to meet you here. It will be okay if you can just type in the chat box because there I can quickly go through all of the messages and see that what actually I need to go through in this lecture or in this discussion, what items I have to focus. Okay, so let me again introduce this topic. Please be active, right? I know it's late evening and it might be hard for you that you're with whole day at work and then now you have to deal with this one, but I think it would be interesting. Okay. Okay, so we have lab professional, we have medical faculties as well, nursing students. Okay. Okay, very good. So that's good to know about you all. Okay, so today what we are going to discuss is the topic, of course, it says Introduction to Healthcare System, Data Landscape, and Clinical Data Ethics. Well, what we will be going through is different type of information system actually, which are used in healthcare. I personally, my research area is artificial intelligence. I'm mainly focused on natural language processing. You know that term nowadays by the term of like Chat GPT, Google Gemini, or all these kind of language model. There's application of natural language processing and artificial intelligence. So the people who are not from, I see that most of you are not from AI or computer science backgrounds. So, I think all of you are medical background. So some of the items I might not be very clear because they belong to your field, but the AI part I will be clear about. Okay, so what we will try to do today, just go through different terms, which when I started medical research, of course, I won't go into the part of the actual clinical research. My research part is just limited to the data. That means the medical data, what we can have, and then based upon that medical data, what type of disease diagnosis or kind of prediction we can make about the patients or about the disease as such. For example, some of my research work has been like when during COVID-19, I start working on X-ray images, and then based upon the X-ray images, we were able to identify whether this particular patient has a COVID or not. And our model was very successful. We actually tried to implement that in some of the local hospitals as well, but at that time there were many government restriction, so we couldn't do that, but it was quite a successful model. Then I start another type of research which I do. This is one type of field in medical, which is image data. So that means in medical field, we always deal with different kind of images, right? Like X-rays, CT scans, all those type of images. So those type of images, they can be helped with the help of AI. We can process those and we can get to some conclusion. Then the second part comes to the data, clinical data, like for example, observations or the clinical notes, what a particular nurse will write or a doctor will write. So these data can also be utilized for doing different kind of research or different type of diagnosis using artificial intelligence. Then the third type of data can be like the quantitative data, like for example, lab results, right? So those numbers, based upon that, also those numbers or the range or a different kind of parameters which we have in medical science. So we can utilize those numbers and then we can come up with different kind of models. So artificial intelligence as such has a great role in medical science, especially when we talk about the medical research. And it can be utilized in a very good way. But the main problem is currently is the electronic medical records. So for artificial intelligence, these EMRs or electronic medical records, they are the backbone of the modern healthcare. Especially when you go to the developed countries like USA or Europe or even Japan, China, all these countries, they have focused so much on developing these standards or digitizing the medical data, so that nowadays you you can't see handwritten notes by the doctor in most of the countries around the world, at least the developed countries around the world. So currently, of course, traditional EMRs, they remain static and time consuming, of course, and then artificial intelligence or using artificial intelligence, we can transform those EMR into smart or adaptive systems. Just a small question here. How can AI-powered EMR enhance patient-centered care? We are talking about the patients, right? Then how can, with the patient care, how can with the utilization of artificial intelligence, we can provide a better care to the patient in the hospital? Any ideas? Early diagnosis, that's good. Personalized treatment, very good. So artificial intelligence based EMR, they can boost patient-centered care by offering personalized or proactive treatment and predictive alerts as well. They can reduce the clinical administrative burden, then they can allow for more direct patient time, and they also empower patients through tailored insight and automated real-time safety checks. Artificial intelligence, just a second, and electronic medical records, if they come together, they can do wonders. EMRs, they are essential tool for storing or sharing patient data in modern healthcare, as we know. Nowadays, you see that almost every hospital, they use EMRs or electronic health records. So if we integrate artificial intelligence into those EMRs, so they can transform these static data into smart and learning platforms. Artificial intelligence can enable these predictive insight with the help of different kind of artificial intelligence methodologies and algorithms, which you will learn through the this course or level one. I think you will have some insight into that as well. And then they can help us in creating a transparent and ethical standard as well for utilizing all these AI algorithms as well. We are going to discuss about this, that what are this ethical standard and how it should be followed. So first of all, so like for example, when we are talking about artificial intelligence, one important thing is we have to understand that AI cannot work without data, right? And that data has to be in readable form, right? So to make that data into readable form, you should, and then there are more things as well. Like for example, there should be standards of that what type of information you are utilizing in hospital, the same kind of keywords or codes they should be utilized in another hospital. And then if you go at the global level, then the same should be utilized in different countries as well. But sometimes it's not that easy. Sometimes different hospital or different countries when you move from, they use different type of coding or code standards. And because of that, the interconnection between different modules or different models become difficult. That's why we are going to discuss in the next few slides. So healthcare workflow, we often think of a workflow as a checklist. For example, step A lead to step B, but in medicine it's quite different. Like for example, A lead to B, but unless C happen, or unless there are lab results from D, or if they are delayed, for example. So a workflow is a set of reoccurring process, right, that carry a patient from the intake and the patient admitted to the hospital to the discharge. So it is the core of daily operation in any hospital. So if this core fails, that means the workflow fails. So the hospital will also fail, because in that case, the patient will not get proper diagnosis, or it will not get proper care, and in the end, there might be some harm to the patient as well. Okay. So when workflow fail, what happened? And why does this matter actually? Why does the workflow in any organization, or especially hospitals, matters? Because when the workflow fails in a hospital, the patient dies. Like, so in informatics, we can talk about, or health informatics, we can talk about this as a Swiss cheese model. So in Swiss cheese model, the idea is that the error passed through the holes in our defenses. So for example, when a nurse has a click 15 time to, or like has to click a 15 time to get a simple analgesic or any tablet for the patient, then it is quite difficult to do all the daily routines. Like, for example, if you are going to convert your system into an electronic health record system or digitized one, and then even to do any kind of activity, a simple nurse has to, for simple tablet, she has to go through multiple processes. Then it will be difficult. Then means you are not on you are not digitizing your system, you are actually making it more complicated, and which will actually create problem in the long run of the system. So we must recognize that wasting resources and burning out the staff ultimately is going to harm the patient in the end. So this is one of the reason that the workflow, when we are designing the workflow for the healthcare, they should be very smooth, they should be very fast, and they shouldn't create any kind of hindrance in any of the person's work. Modern healthcare relies on the complex digital ecosystem. So often we treat the computer screen as, like, for example, uh, we stare at the obstacle to care. That is, if we are putting a system in the middle, like for example, a doctor has to go onto the system and enter all the details about a patient. So it's a kind of creating delay for the treatment. But actually, this is not true, because when we have this system and when we have this data entered into the system, it gives us long-term benefit. So you can consider these as the nervous system of the hospital. So, like for example, if a lab information system is not able to provide information to the electronic health record, then that information has to be transferred manually, right? And if you are transferring manually, that it will create more delays than the doctor entering data into the health record. So overall, when we put all these things together, it becomes a complete system, and it becomes more useful, or it create a faster workflow in the hospital than actually we do manually. So that's the reason that we try to convert or modernize all the data. So there is a term called data modernization. This term was coined by I think by CDC. So during COVID pandemic, we know that it had a profound and ongoing impact on the global health, even the economy and the society. So the effect of one impact of this COVID was data modernization, that we are trying to convert all the data into electronic format, so that this data can be processed with the computers, and the computer can also understand that data. There are two different things. One is that the data is in electronic format, but the computer is not able to understand that. And the second thing is that the computer is able to understand. So we call it machine readable data. So when we are modernizing the data, we are not only converting this data into electronic format, we are also converting this data into machine readable format. And because of which there are different kind of system come into place, like for example LIS, laboratory information system, or RIS, radiology information system, or PACS, for example, picture archiving and communication system. LIS handles, of course, the chemistry and biology related data of the patient. RIS handle the administrative side of the radiology. Then the PACS handle the actual medical images. So we'll go through one by one, all of them. The LIS, it manages and orders the specimen tracking and analyzes results. For example, when you order a blood test like CBC, the LIS take over, it prints the barcode, tells the analyzer what to do, and checks if the machine is calibrated or not. Then the EHR only see the final number, that means the generated barcode number. But all the things, all the heavy lifting, you can say, it has been done by LIS. So if a result is, for example, if a result is pending in EHR, the bottleneck is usually in the LIS workflow. So if the LIS workflow is not smooth, then it will create delay in providing the result to the electronic health record. So that's why the workflow is matters in the healthcare system. Laboratory data or lab data is the clinician's comfort zone. So, like we know that the quantity is quantity objective, and the informatics rely heavily on the lab informatics data or LIS data. It uses strict in standards, like for example LOINC codes, right? This allows us to graph a patient's organ function, like for example kidney function. It can be done over a period of time as well if you have the record. But we must be careful that if there is we have this data, but there is no context to that data, like there is no time of collection, or there's like medication administration has not been taken care of, then this data can be misleading. So if you have a system, LIS like system, you can store all this information, and then they can also be affected or reflected in the quantitative numbers which you will get after doing the test. So then another thing is like for example there's an interoperability issue as well when we are using different kind of system. So what is interoperability? That means, like for example, you have a system by one manufacturer, and there's a system from another manufacturer, and they are utilizing different kind of units. Like for example, one is utilizing mg per deciliter and another is utilizing millimole per liter. Okay, so now in this case there will be a problem as well, right? If you just give this data numbers to the computer will not understand which is what. So that's why also that when we say that the data should be machine readable, so interoperability issue comes there. We are going to discuss about interoperability issue later. Uh, so I'm just going to go to the next section. So then there is another issue can be reference ranges as well, like age, sex, population specific verifications or variations, sorry. There can be pre-analytical error as well, like for example, labeling error or sample degradation before digitization. So this all kind of problem happen. Do you think that the normal range change based upon the population? Does the normal range of, like for example, CBC or any other test you are doing is changed based upon the population, right? So if it is changes, so that means these kind of information has to be there as well, right, in the system. So these systems, they should record all these kind of information. So like, for example, when as a nurse, you are entering this information, or as a lab technician, you are entering this information, you should be careful about this information as well. Because when we are actually entering all these data into the system, we are not only taking care of one patient, we are also creating a data base for the future of the medicine as well. Because nowadays, what we are doing, that whatever data we have, we are utilizing that data to convert this data into a AI model so that AI can help us in doing different kind of medical related diagnosis, medical related, like for example, personal treatment or personal patient care. So all those kind. So it's not only just related to one patient, it also helps us in building the future of medicine as well. Then the second type of data or information system which we have are the RIS, or the radiology information system. Some of the people call them that RIS. These are just the front desk of the PACS, picture archiving systems. But this actually, this a little bit, you can say, variation or confusion here. RIS system, they handle the administrative task, that like checking the patient in, verifying the insurance, and generating the order list for the, like, for example, CT technician. So it deals with the text, not the image. And then we have the PACS system, which is also a picture archiving system. Okay, so these are the library where this is where your actual CT scan, X-rays, MRIs, they actually get stored there. So when you click in the, like for example, you have an electronic health record system, and you click on the link of the image. So what actually you are doing, you are accessing that image from these packs, from these picture archiving systems. So it's kind of, you can say, create a command and create a connection with the PAC server, and then get the data from the PAC server, bring it to the EHR, or electronic health record system, and then it displays that information there, or that image there. So it require optimization for the storage, because as we know that medical images, they are usually very heavy. Now we try to capture as much detail as possible. So their size is bigger than a normal camera pictures. And then we also need a specific algorithm which can render the image and understand the image and convert the image into, you can say, like a photograph, so that you can see. So medical imaging, there are again in the medical imaging also there are multiple standards. Like for example, PACS is one of them. Then another is DICOM, or digital imaging and communication medicine, in medicine. So these are different systems. I might be a little bit wrong here because I'm not from medical background, but as per my research, these are different systems which are utilized in medical field. Okay. So for the administrator here, I think this is the reason that there's too much cost for the medical storage. So and for the other people here who deal with, like for example, CT technician and other people, clinicians. So the metadata for these images becomes very important, because that metadata actually help the artificial intelligence tool for starting to assist in reading these images or these scans and giving you some output or some prediction about the disease or about that particular image. For example, let's say there's one X-ray, right? So with the help of AI, you can identify like based upon the texture, shape, or density of the image, you can identify if there's any issue with the patient or not, and then you can confirm that with the help of the actual human expert. Okay. So medical images, they are not just picture to look at, as we know, they are data to be mined. And artificial intelligence might see texture pattern in a tumor that predict responsive to chemotherapy. So pattern that are uh, patterns the human eye literally cannot see. So you might have seen or read the examples that there have been many cases in which like AI predicted the cancer before 5 years in advance. Like for example, it predicted, then the doctor thought that it is just a false positive, but actually after 5 years, that patient developed a tumor and uh, it was diagnosed as cancer. So AI can look at the, you can say, very, very minute details, and then it can give the predictions based upon that. So having a proper data about the images or whether it is metadata or any other clinical data becomes very important in the age of artificial intelligence, because nowadays we are shifting towards using artificial intelligence in medical field for almost everything, whether it is a diagnosis, whether it is managing of your documentation or creating a smoother workflow, or even like creating a faster system for lab tests or clinical tests. So this diagram, let's look at like the movement of the patient throughout the system. So if you see this, like I try to create a diagnostic loop here. So if you see here, like for example, the patient is admitted, but like for example, after admission and scanning, all the things has been done, and there is some delay at the, let's say, the CT scan result does not uh, goes to the doctor, for example. So what will happen if the doctor is waiting just for the CT scan result, and because of some intervention or there's some problem with the workflow, the doctor is not able to get them. So then he will not be able to, like, for example, manage or diagnose the patient. He will not be able to provide him the medicine. He will not be able to do the actual analysis, which has to be done based upon the results or CT scan he has asked for. So that means every step in the clinical journey is dependent on another step. So that's why, again, this becomes very important, the workflow part. Administrative workflows, the usually there is always a conflict between the clinician and administration. So everyone thinks that they are kind of stopping the work of the another one. But if the supply chain workflow fails, for example, from the administrator point of view, then it is possible that all the physicians or the surgeons, they will not have proper equipment and other things required for the proper diagnosis. And vice versa, like for example, if the physician is not there, that there will be nothing to administer, right? So these are not separate entity, but they are, you can be considered as a symbiotic system, and they are dependent on or interdependent, dependent on each other. So this is one example that how where like administrator and clinical workflow correspond or uh, interact with each other. So it's just a description about this. Let's talk about the data now, the diagnostic loop, which I just discussed earlier. So, for example, you are using a electronic health record system, EHR, and you order something in the EHR. For example, uh, you could order a test, CBC test, for example. So now what will happen that message, because it's CBC test, so it will go to the library information system. Then the lab tech will do some work, right? And then they will send the result back to the EHR. Then uh, each EHR will present it to the physician. But what happens if this loop breaks, for example? Like, for example, the order has been sent. That means you ordered the test, but you never received the result. So now you have to identify where the problem is. So again, which will cause a delay in the diagnosis process. So that's why the importance of data becomes very important in all that, especially when we say that digitizing the healthcare system. So if the data is proper and it is accurate, then all the things or all the system will work properly. But if there's any problem with the data, like for example, there's a problem with the interoperability, means you are two people are not using the same coding language, right? So in that case, the system will not be synchronized. Or for example, let's say you are you have a LIS by one provider and EHR from another provider. So, and let's say, for example, both are using two different standards for providing the information. Then again, it will create problem, is at least for the computer, because the data will not be synced. And in some cases, you might have to do the test again, which will also create problem for the patients as well. So that's why one of the reason behind using data same standard across all the systems. Electronic health record, they are the defining tool for modern healthcare workflow. But it is also possible that they can also be disadvantage for the modern healthcare system. So like for example, if you are using EHR, then of course you don't have to write handwritten notes. And then if you are not writing handwritten notes, that means it will be quite clear for everybody in the loop to read that and understand that. But at the same time, if the system is not designed properly, it can also introduce alert fatigue. What is alert fatigue? Means, for example, let's say it is giving you update about each and everything. There are notifications. And like, for example, there is a notification that the lab has received a sample, for example. There is a notification about it. So when a physician will see all these notifications, then it is possible that he might ignore some of them. And for example, if the next notification is critical drug interaction warning, for example, then it is possible because of this fatigueness, the doctor or physician has ignored that one. So which will also create a problem in the system. So when we are designing this type of system, so you have to make sure that when you are or even you are purchasing this type of system, so you have to make sure that you understand that what type of system you are purchasing and what of information it is going to transfer, whether this information is okay, is too much, or is too less. So all these things are also important when we are going for any kind of EHR system. Then human factor, of course, we have biological limits. Of course, in high stress environments, our working memory might saturate. So if this workflow system is not proper, then it might create saturation for us as well. So it acknowledges that you will be interrupted most of the time if it is not proper. Like for example, as I was saying that it is giving notification on every event. The system might like this, when we are designing the workflow for this system, we should consider this, that the human factor is also there, and we have to create the system in a way which will not affect the human too much, whether it is creating alert fatigueness or it is creating memory saturation. The data part, electronic health records, of course, when we are creating these health records, so there's a data is involved, electronic data. So the data can be of two types, like a structured data, which is in the form of coded fields, vital signs, medication list, and then the unstructured data, for example, like clinical notes or discharge summary or nursing narratives. So now the problem with here, or the challenge here, is to extract the meaning from that text without losing the human nuance you put into the, let's say, unstructured data. So we have to be very careful when we are utilizing any kind of EHR, whether we are putting structured data there or unstructured data, because now this data is going to be utilized for artificial intelligence modeling. And if you are utilizing it for AI modeling, the model will not understand the human terms, right? It will just understand the standards or the language, which, like for example, like coded field or vital signs, it will understand those numbers. But if you put some, like for example, here I have shown two example. One is the structured data, another is the nodes. So, like for example, it will not understand what feels tired mean, right? But it will understand, okay, this is the medicine and this is 20 mg daily. So when we are creating records, we have to be careful that what type of data we are going to create. So there are generally we can categorize data into two categories. One is structured data and another is unstructured data. Structured data is the grid. It fits neatly into rows and columns. It's easy for computer to graph and analyze this data. Then unstructured data is usually the story, so free text. It captures the nonsense of the patient's complaint, the uncertainty of a diagnosis, and the context of the problem. But the problem here is the computers understand the structured data or the grid, okay? But the physician or clinician below the story or the free text, because it gives them the ability to write the exact information what they want to write. So we have to find a way that how to bridge this gap so that the computer, because the computer is understanding structured data and the clinician or the physician is understanding unstructured data. So we have to come up with a solution which can uh, which can fill this gap of unstructured and structured data. More detail about unstructured data. So when you type a paragraph about a patient complex social history, for example, you are providing excellent care for the next human being who is going to read, let's say maybe the next nurse who's coming after you, that they will be able to read through it and then they will be providing the care based upon that. But when it goes to the computer system or the drug interaction system, the paragraph become invisible to the computer. Okay, when we because to understand that paragraph, the system has to utilize natural language processing to understand that what does this particular paragraph mean. They are not nowadays, whatever, even if we have these chatbots or these large language model, still they are not enough. They are not perfect. So we cannot rely for someone's life on an accurate model. And it is you might have seen that there are many research around this, that this particular language model is hallucinating and they are giving some random information, or they are creating some sources which does not exist. Okay, so the output of these model, of course, we nowadays we try to rely them, but it's not reliable. It can be just some randomly generated information, because it's just a mathematical model which trying to put different one together. So that's why structured data becomes more important. So structured data, it feels rigid. It forces you to pick from a list that might not be perfectly described by your patient. Okay, but this rigidity, it is help us in saving lives, because the data is structured. The computer can instantly flag, for example, a medication error, or plot a growth chart, like for example for different symptoms, whether the disease is increasing or decreasing, or it can match a patient to a clinical trial, for example. So structured data is the prerequisite for, first of all, for the interoperability, and as well as for developing a smart diagnosis system. So because of these reasons, the data quality for the electronic health records becomes very important. So if we just go to the historical data, whatever we have currently, like for example, if you start doing medical research, In medical research, you will find that the most of the data you will see from EHR is not very rigid or very structured. You can call it as a dirty data. It's fragmented because the system, main reason for that is because the earlier system, which we start using for EHR, they were built for billing, not for clinical insight. So when we use this data for research or to train artificial intelligence, we have to be very careful. Because, for example, there's you made a mistake, for example, in one of the diagnosis, and you copy paste that note into the next for today's diagnosis, for example. So what will happen that the mistake which happened yesterday, it will propagate throughout the system. But if it was structured data, so in that case, that mistake will be flagged automatically by the system. So that's why the data quality becomes very important when we are recording information about the patient in any kind of electronic format. This can be one of the most important slide for today, I think. Like, for example, a data quality cycle when we are talking about. So when let's consider an example. When you select, let's say, a symptom like unspecified pneumonia, because the first, like for example, when you are entering the information in the EHR, this was the first option in the drop down menu. And so what will happen in this case? You like unspecified pneumonia, so it's not quite clear that the reason or the actual diagnosis. So what you are actually doing at this time, because of maybe laziness or slowness, you are degrading the quality of the data which you are creating and which you will use in future. So in artificial intelligence or machine learning, we say, or even in computer programming, garbage in, garbage out. This is the golden rule of informatics. That means whatever type of data you are going to provide to the system, you are going to get that type of output. So if the data is not clear, it's vague. So the analytics, whether it is model or whether human analytics, they will not be able to understand or get something out of it. So our research will be flawed and our AI tools will become unreliable. So data is not just a byproduct of care, it is the driver of care in the current or in the modern healthcare. So we have to be accurate when we are providing data to these systems. Like for example, whether we are selecting diabetes or type 2 diabetes with this retinopathy. So all we have to be very accurate that what information we are providing to the system is very accurate. Then second, then completeness. We have to make sure that we can fill as much information as possible. Because when you leave the fields blank, then the predictive models, they will, this becomes like, you can say, a gap for them. They are not able to understand that what you should do, what this particular field actually meant for this patient. Then using the same terminology also becomes very important across all the care team and across all the system which you have. Then there is usually, like for example, in most of the like system, these type of system which you will see, there's an option of other or unspecified. So these are like when you are not fitting any of these things. But more because of laziness, people what they do, they select other or unspecified and then they write the notes. So this also create bad data. So one suggestion here is to respect the code, like precision in SNOP or in ICD. Then whatever type of information you are providing, just make sure that it's accurate and complete. Another type of data which we might have is the sensor data. Nowadays, it has become like high contribution of these AI model sensor data. Traditionally, we only have data on patient when they are sick enough to come to the hospital, or uh, like when they are bringing the reports or medical results. So that was the only way to get the information from the patient. But with the innovations, with the use of personal healthcare devices, this has changed nowadays. especially the sensor. Sensor changed everything. So they nowadays they provide continuous longitudinal data, the patient-generated health data. It allows us to see the gap, or you can say the white space between the visit, right? So, like for example, like the heart rate, whether it is spiked for a patient before he fell or not, for example, right? Or like for example, if there's a patient of Parkinson disease, and so if their gait was changing uh, before actually the disease was predicted. So all these type of sensors, like whether it come in different form, for example, in the form of wearables, in the form of implantables or ambient, so they can help us to get continuous or episodic data from any patient, and then we can come up or utilize this data for training our AI models. But there is, of course, and everything is not perfect. So there are some challenges with sensor data as well. Like, for example, data overload. This is one of the biggest challenge because if you have a sensor, so it can monitor 24 by 7, right? So the danger here or the problem will be data suffocation, for example. Like you cannot ask a busy nurse or MD to look at weeks worth of smartwatch data. You need some intermediary layer or some intelligent algorithm that will filter out the noise and only provide the alert uh, when there is a problem, right? So we also have to ask if this type of data coming from the sensor, whether is it accurate or not, or whether we can rely or put like we can rely for the prescription based upon these data which is coming from the sensors. So there are many challenges in this one, but again, this is one of the you can say largest contribution of the clinical data nowadays. And many AI models are being developed just utilizing these sensor data from the wearables or different kind of medical devices. So again, now another problem comes here, another challenge is the interoperability challenge. Because now these type of products, healthcare products, they are being developed by different organization or different manufacturers. So there's sometime they based upon the country this particular manufacturer is, they start utilizing their own country's standard, and that creates problem. So like for for example, a system often speak different languages. What does it actually mean? That means it's actually utilizing different standard for sharing the information. So, like for example, HL7 for the standard for messaging format for the text data. Then there is another standard for modern standard for web-based data exchange, FHAIR. So this can be utilized. The advantage of utilizing this standard for these devices and all other system is that this data is query based. Like you can easily query through the mobile app, through the website, and through any kind of system. So the data exchange between systems become easier. Why we are actually focusing too much on data exchange between different type of system? Because now when we are talking about modern healthcare, we are not just limited to one hospital or one system. We are talking about global healthcare. So, like for example, you might have seen the news that there was a doctor in USA and he operated a patient in China, right? So that means we are connecting the doctors across the borders as well, and we are doing that in real time. So this type of data exchange become very important. That means the when we are sharing this information with the doctor in another country, we have to be sure that it is at the same utilizing the same standard or same coding as they are utilizing. So that's why utilizing the global standard becomes more important for the interoperability of the data. One thing which we also say is silos. Does anyone have any questions meanwhile? No questions? Okay, I have one request. After 5 minutes, we'll be having a break for 5 minutes, 5 to 10 minutes. You can say coffee break. Actually, I have to go for prayer. So we'll just take a short break for 5 to 10 minutes and then we'll start again. So I'll just complete this section and then before going to the next section, we'll have a small break. So breaking silos or interoperability, what actually it means. Currently, we work even in the hospital or especially in the countries when we say that we work in the different silos. Silos means like you can say one limited area, right? So the data lives in isolated silos, whether it is lab system or radiology packs. Okay, so for example, for a patient is one biological unit, right? So data is often, but their data is often scattered across 10 different servers. And those servers, they don't speak to each other. They don't communicate with each other. There's no standard for information sharing. So when a workflow requires a human to transfer number, let's say, for example, from a PDF file to the electronic health record. So what we are actually doing here is 100% chances of error. So we are inviting error. So to create a proper workflow for optimization of we require interoperability. That means we require to utilize the same standard across different systems. So whether it is your LIS, whether it is your RIS, or whether it is your PACS, they should utilize the same system so that they can connect with each other and then with the EHR, and then in the end you can utilize AI to get some decision making support for the patient, for example. So some examples we already discussed, like for example, HL7 is one of them, which is I think HL7 is the standard development organization, and they have developed this FHAIR, Fast Healthcare Interoperability Resource. So this is a standard created by HL7 for exchanging the healthcare data using web technologies. And why we are focusing on web technologies again? Because we are trying to make the system global and the exchange of the information is smooth across across the web, you can say. So now the next part, if we are able to find out the system, so next part become integration. So if we if you want to create a patient-centered record, regardless of the source, so we should have interoperability. Then again, it comes the same thing that they should be speaking the same language. So the future is not about choosing between EHR or the image or the lab. It's about creating a multi-model fusion, combining all of them together to create a high definition picture of the patient. So this is you can say one of the target, or you can say future innovation target or in the medical field. We already discussed this one, but I'm again putting it because I need to discuss the next part, which is about different standard. So we'll start from here after 10 minutes, if that's okay by you. So we can have a small coffee break if you want, right? And then we'll start after 10 minutes. Is that okay with everyone? Okay, so it's currently 4:55 here. So we will start at 5:55. So I think it should be 7:35 there, right? So it's 5:25, 7:25 here, there, right? So we'll start at 7:35. Hello, everyone. Should we start?
Yes, sir.
Okay, thank you. The screen is still shared, right?
Yes, sir.
Okay, thank you. Okay, so we have been talking about interoperability. Why actually we have been talking about this one? The reason is that there are different systems, and different system might use different kind of codes. Okay, so for example, there is a hospital A records heart attack, and this another hospital B, for example, they record it myocardial infraction. Then there is a human, for example, he knows, or a doctor, he knows that these are the same thing, but the computer often does not know that these two things are same. So this difference between the syntax, that means the sending the letter, and the semantic, that means understanding the language, without having a semantic operability, multi-center research is nearly impossible without having a proper expensive manual labor. So that's why coding in standards in medical science act as the universal translator, and they map these varying terms to a single, let's say, alphanumerical identifier. Okay. And it is also possible that different standards, they are not equal always. That means one disease is not always possible that the same disease will have or same information will be available in another standard. For example, the two primary or the main standards are ICD-10 and SNOMED CT. These are very commonly or very widely used standards. But there are some kind of differences as well. And there are, like, for example, one is mainly for the classification work, and the another was is for the clinical precision. So these two are very widely used standards. Okay, but there are some more as well. For example, we have a standard like LOINC. This is the universal language for the lab results and observation. Then RxNorm. This is the standard normalization for pharmacy and drugs. So to fix the problem, we must enforce standards. So as clinician, you don't need to memorize the code, but you must understand why any organization or hospital push for the structured data entry. So when you pick from a drop-down list rather than free typing, you are mapping the patient's condition to one of these standards. And that means you are making the data instantly globally searchable for the researcher or even for other doctors. So we'll discuss the first two in detail. So ICD-10, or International Classification for Disease, this is the language for the billing and public health. It groups diseases together. It is excellent for telling the government how many people died of flu, for example, last year, or to telling an insurer why a hospital stay is justified. So ICD-10 is a classification system. It forces you to group a patient info into a pre-existing category. It is vital for financial health of the organization, but sometimes it lacks the detail needed for the clinical care. So that's why we have another standard, SNOMED So this is the language, or it is the short form actually. This short form of systemized nomenclature for medicine, CT for clinical terms. Okay, so this is also called as the language of the medicine. It is very vast. It doesn't just group the diseases. It maps the relationship. So for example, it understands that, like, for example, bacterial pneumonia is a lung disease, and is an infection and is caused by the bacteria. So it understands the semantic of what we were saying earlier, that syntax and semantic. So it's understand the semantic or the meaning of what we are writing or what we are selecting. So whenever, like for example, when you have your electronic health record system, so whenever you do any kind of search for the diagnosis in the search bar, so what you are actually usually searching is this data set, or the data set created using SNOME. Okay, so even if the system spits out any ICD code for the bill data, still you are searching this data set. So this is the ideal for the clinicians, and you should be documenting using uh, systemized nomenclature for medicine concept when you want to be precise about uh, putting the information into the system. We discussed this term garbage in, garbage out already. So when we are talking about standardization, it's not just about tidiness. That means we are actually putting the actual information. It's not just about that. It's also about the equity. So if we have only standardized data, for example, usually what happens, like if you go to very high class hospital, like for example, Apollo, Fortis, or means the top class of the hospitals, right? So usually they use this kind of system, right? They use a standard system for restoring the patient record. So what will happen? And usually the patient will be there of high class people, like who are rich, right? The normal people or the poor class will not go into high class hospitals, right? So what will happen if we don't have standard data or standardized data into the you can say hospital which treats poor people as well, right? The problem will happen that when we are developing AI models, these models will have data from these high class, let's say high class hospitals, which actually utilizing all these standards and digitizing their data. So the AI model will be tailored only for that. It will not even consider the lower class people or the poor people, right? So like all the researcher, academic center or research algorithm, they will only work for the population those centers serve. So it will lead into poor data quality, and which will also lead into hallucination, just like we have in large language models nowadays, right? So same thing, the AI medicinal model will also start doing the same thing. So that means overall, if we stop using standardized technique or data entries for normal hospital or for the hospital which treat the poor people, the problem will happen in the end, that it will lead to the, of course, the dangerous conclusions will be there, and then the clinical trial of the models which are developed, it will be harmful, because as the first question we discussed today was that whether the population affect the range of the clinical data or not. So all of you said yes, that of course the population is one of the major factor, right? It can change based upon the population. So same thing will happen here as well. That for AI model we are utilizing the data from only one class of the society, then that means that model is being developed only for that class of the society. So uh, currently, at least in the modern healthcare, we see, so we stand at, you can say, two-way or you can cliff in the modern medicine. We have more data than ever before, and we are utilizing it for research. Uh, but it is still difficult to utilize all of this data for research. We are not just talking about IT problem because of this data, that we are not able to develop or process this much amount of data. We are also talking about the ethical mandates as here. We are like, for example, now we will discuss the ethical part of this part of medical data. That what are the ethical hurdles are there in utilizing the clinical data. So our target should be in a way that when we are utilizing this clinical data, we should not break the fundamental trust we hold with our patients. So unlocking the hidden value in electronic health records, because every time you enter a node into a electronic health record or EHR, you are not just documenting a visit of a patient, you are also creating a data point, and that data point could cure a disease in future. So however, the vast majority of this data is trapped in the free text or incompatible format. But still, our goal is to turn the exhaust of this healthcare system into the fuel of the discovery for the future research, so that we can utilize this data uh, and develop some artificial intelligence models. Like, for example, currently the reality is that 80% of the medical data, it is in unstructured format. And if it is in unstructured format, that means it's not usable for developing AI model. So we first have to convert this data into a standard format, then only we can utilize it for converting this or for developing AI models. Another thing with the data is we discussed one case that if you have electronic data only from the high class society, then there will be problem. So because the data is not neutral, right? If our training data come only from, like, for example, from academic medical centers, so then that data may not apply to the rural population from a village. Or for example, if we use data from sensors, so now another question here can come that, okay, this is the sensor data, who own that data? We must ensure that we embrace all the sources, all these data sources, and we do not automate inequality when we are developing AI models or developing this type of diagnosis tool, so that we don't sacrifice patients' privacy for the convenience. Like, for example, one of the question which usually asked among the researcher, that we are storing data from the patient. So if, and nowadays, you know that this is a $1 billion industry for selling the patient's data, right? So if the patient data is sold for millions to the farmer, should the patient be given a share in that data or in that profit? So uh, ideally he should be, and ideally he should be asked before even sharing that if that your data is being shared with this particular organization, are you okay with it or not? So AI or artificial intelligence is not neutral. We know it. We have developed it. If you know any AI developers who have developed AI models, you will understand that there are 100% possibility that you can train an AI model to do a particular thing only for a particular class of people. So, for example, let's say an opinion is written in code, for example. If we train a skin cancer detection algorithm only using the images from the patient of light skin, for example, right? Like, for example, let's say you collected the skin cancer data from the European patients only, right? So now the European patients, they have light skins. So now if you develop this model, AI model for detecting this skin cancer, now you want to utilize that data or that model in India or in Africa, will that work? No, definitely it will not work because it will be biased. It hasn't seen that kind of data, right? It hasn't seen brown skin. It hasn't seen black skin, right? So in that case, it will create problem or it will create biasness, okay? Because the model was not trained. It was just taught based upon light skin. So we are also at risk of automating historical inequalities and hard coding them into the future of medicine if we don't record all the data properly. Because whether we want it or not, all of this data or the future of medicine is going to be AI assisted, if not AI automated. In almost, you might have seen till now that, uh, okay, actually, I did not. Is there anyone has any question? Okay, I saw the message just now. Please repeat your last statement. Okay, we'll keep it at this way. Okay, so okay, regarding data into drop drop down menu. Okay, what part is not clear? Should we go back to that one? What actually I was trying to say there, that when you are selecting the data from the drop-down menu, just make sure that you select the accurate information, because sometimes there are options like others, unspecified, right? So if you select those other or unspecified, you don't go pinpoint the exact problem or exact issue or exact information, then that data will be useless for the AI models to develop with. Okay, same thing for the other information as well. So that was the main that I was focusing on, that when you are selecting, just make sure that it is proper data. Okay, so where were we? Okay, yeah. So means the data, we have to consider all type of data. If we just provide only one class of data, it is going to create problem 100%. There have been many cases in the past. One problem is called as Obermeyer study. Obermeyer study. They design an algorithm to find the sickest patient to give them extra care. Like for example, in a nursing home there are some patients, so they want to find that, okay, which patient is the sickest one, so that we can provide them some extra care or extra nursing support. So it is this algorithm, what it did, it is assumed that yeah, one of the criteria for this algorithm was that how much money you are spending on the healthcare, that means more sick you are, right? So, for example, you are spending thousand again and again on your health, so that means you are falling sick again and again, right? So this algorithm had this assumption when they were developing the algorithm. But because of this is like systematic access issue as well. It was developed in United States, so the Society of Black Patient there, they generate lower income, or you can say they have lower cost. So that means uh, the cost to the hospital for the black patient was lower, and for the white patient it was higher. So what algorithm did, because it was calculating based upon that how much money you are spending on your health, so you are that much sick. So this algorithm start favoring the white people because they were spending more money, right? Even though they were not that much sick, right? Maybe because of the system there. So the what I was trying to describe here is that AI is 100% possible in AI algorithms, that you can develop a biased algorithm or without even knowing or without any intention of doing so, because the data which you fed to the system or to that algorithm, it wasn't proper. So that's why the data for any artificial intelligence model or any artificial intelligence software, data becomes the most important part of that, and that's why we are focusing on utilizing the same standard, and even utilize providing more details. And even for you are treating any kind of patient, whether you are working in a government hospital or in a very high class hospital. I'm not saying government hospital are not high class, I'm just trying to just give you the definition usually how it works. Like usually the private hospitals, they spend more money on their infrastructure, so they charge much higher than the government hospitals. So I'm just using that analogy. Here, I'm not being biased here. Okay, so this becomes very important, that why we need this kind of data. Another example I can give you from AI, this one, I think everybody knows about Amazon. There's a company, e-commerce company. So they developed a model, AI software, you can say, for identifying the best person for their team, for example, so that they can interview. So in their recruitment, so they put this AI model. So any CV was coming to the HR, so it was going through that AI model, and AI model was selecting whether this interview should be done or not, if organized for this person or not. So they realized that for 3-4 years, the model did not select any female candidate. The model was always recommending male candidate. And then they went back into the system, and then they checked that most of the CVs which were fed to this algorithm, they were for male candidates. So that's why the system automatically built this biasness, that if there was any female candidate CV, it automatically rejected that CV, even if that girl or that lady is better than most of the CV fed to this system, because it was just seeing that this is female, so it was just rejecting. So then they changed the algorithm, of course, and then they scrapped that algorithm. But again, it is just telling that it is just not theoretical that the algorithm can be biased. It's actually practical. And we have seen this during COVID as well. You know, pulse oximeters, everybody use this in medical field, right? So they often overestimate. If you might also try to, maybe if you are using one from manufactured from Indian company, so it might work best for all the people. But if you use some oximeter, excuse me, sorry. My apologies. Actually, I'm delivering this lecture from home, so my kids are roaming around. Okay, so yes, we were talking about pulse oximeters. So I was saying that it is possible, like if you are using from one pulse oximeter from Indian company, it might work perfectly fine for all the Indian patients. But if you are utilizing from, let's say, from European company, you are utilizing. So it is possible that they overestimate the oxygen level for the darker skin patients. And this actually was identified during the COVID pandemic, that they start the oximeter, the company which developed these oximeters, they calibrated those oximeters on light skinned people. And when they were actually utilized for the uh, dark skinned patients, so they were flawed, and the algorithm was giving the wrong results, and they overestimated the oxygen level for the patients with the darker skins. And because of this, many patients suffered, and that's how they came to know that this the problem is caused by these oximeters, because they are not providing the accurate readings. Okay, so again becomes the same thing comes again. The data becomes very important, and the right data is the you can say foundation for developing a good AI model. The solution to artificial intelligence bias is not to, of course, ban artificial intelligence. It is to keep the uh, human in the loop solution, which I call it human in the loop solution, We call this, we can also call this as augmented intelligence, like augmented reality. You know, you might have heard the term augmented reality. So we can also use the reverse term for that is augmented intelligence. So we need the clinicians and the nurses to apply these small tests. If an algorithm suggests a discharge for a patient, for example, you are using AI model algorithm suggesting that this patient is okay, so this patient can be discharged. So you, as a clinician or the nurse, you should see whether the patient is stable or unstable, and then you should not only trust the system, you should trust your judgment as well. Okay, so use the technology as the assistant. Don't use the technology as a boss. Excuse me. For the people who are in administration here, like department heads, so when you are buying a new software suite, you should ask about the cost and interoperability. That's the first important thing when you're purchasing any software, that whether this software is able to provide interoperability. That means whether it can work with other vendors as well. Like, for example, you must ask about the demographics, whether this has been tested with all the different kind of people. Like, for example, you can ask them the performance data broken, then maybe you can ask them that to break down that data by race, by gender, by age. And if they cannot provide it, uh, my recommendation would be that don't buy it, because it has not been calibrated according to or considering all the population. They have just calibrated on a bunch of people or one set of people. Okay. So, and again, because it's a software, as I discussed the case of Amazon CVs and this Obermeyer. So it is possible that when you are doing the utilization of this algorithm or this software, that they can learn some patterns and start doing biasness. So that's why continuous audit becomes important of these tools. So you can see that it is just the sterilization process for these softwares. Technology can either widen the health equity gap, or it can close it. It can do both. The difference is not in the code, it is in the ethics of the people who are actually utilizing it. So treat the data with the same reverence that you treat the physical body. You will, if you do that, you will navigate the future safely. So next time when you log in into your EHR or look at the predictive score or any software you are using, so you should question yourself that from where these numbers are coming from, who does it help, this data, who might be who might this data hurt. So you should focus on these questions as well when you are providing or recording or any kind of data into EHR, or you are using decision support system for making your predictions or validating your decision. So we should be careful about that. Now, when we the the case of like as I think I discussed that the patient data is a multi-billion-dollar industry in nowadays, because this data is being used for training the AI and for different kind of drug discovery. So we used to think in past that if we remove the name of the person and their birthdays or their let's say ID number, like for example passport number or any kind of ID number like Aadhaar card in India, for example. So it is enough, but actually that's not enough. With nowadays we have different kind of external data points, like for example credit card swipes are there, then location data is there, then social media is there. So even if we remove these things, like for example, name, birthday, and other card information, still your data can be linked back to you. So your health record can be re-linked to a specific person. this is known as mosaic effect, which is like combining de-identified data sets to re-identify individuals. So, like for example, very simple harmless data points like your zip code, admission date, all these things. When they combine together, they can reveal the identity of a person. Okay, so and nowadays, I don't know about what's happening in India currently, but here we had a drive from the government side that they ask the people or citizens to participate into the genomics data. Something survey was done here, so they asked the people to participate into that, and then they recorded their genomics data. So now if we have the genomics data of any individual, it doesn't matter how you try to remove all of their information from the data sets where you are recording the genomics data. The mathematical model will make sure that you can re-identify that person, because the genomics data, of course, it's unchangeable, right? So they can easily identify any person based upon that. So and AI, when we are talking about AI, we are actually talking about mathematical models in a way. So if you can solve anything mathematically, you can solve that using AI as well. So that means in future, if we have genomics data of the people or the citizens, you can easily identify those people anywhere in the world. So uh, this is where the ethics in clinical data comes into practice. So when a patient, for example, when a patient tells a nurse about their substance abuse or drug abuse or doing different kind of uh, drugs, so they trust the information or they trust the nurse that this information will be utilized for their care so that they can get proper treatment. They don't think that this information is going to be sold to the drug companies or a training AI model. Okay, so excuse me. So large data set, they are routinely licensed to third parties, we know, while it is legal in most of the countries, but we have to ask the question whether is it ethical or not. If our patient stop trusting us, like for example, as one patient come to you and he's telling you about his disease and everything, and you sold that information to an insurer, for example, when he will come next time, he will tell you anything? Most likely no. Most likely he will not even come to you, right? So if the patient stop trusting the doctors, the physicians, or the hospitals, so now what will happen? Then the ability to diagnose and treat them will also collapse. Okay, so we must advocate for transparency in our institutional contracts. We must make sure that whatever information we are sharing is also ethical. It's not only just legal. So there are many regulatory landscape. So if you are using in international involved in international trials, you know that uh, there's an organization called HIPAA. What do you call it? HIPAA. So and then there is another organization. This is from USA. Another organization, GDPR, which is Journal Data Protection Regulation, is in Europe. But GDPR is more stricter than the HIPAA one. So they see the patient as the permanent owner of the data. So even after the patient leaves the hospital, their data is also is still under the protection of the patient, for example. So patient have a say before their data is being shared with anyone. For example, if a hospital is going to sell the data, so he will first inform this patient. So when you are designing a research or any research protocol, you should focus on that your research satisfy the strict strict standard, not the loose one. Okay, like for example, you should focus if you are trying to develop some research utilizing medical data. So my recommendation would be that you focus on GDPR standards, not the difference between here. Like usually, the people in US they consider it as just a checklist to avoid fines, and a specific same thing GDPR. But GDPR, what they have done, they made it more broad and comprehensive, and they have shifted towards the global standard in treating the privacy of a patient as a human right. So that's the main difference between these two regulation. And for a global research collaboration and medical tourism, having a standard which is globally acceptable, which is treating privacy as a human right, will be widely acceptable than the one who is just a checklist, you can say, or just to avoid fines. Maintaining the bond of trust. So, for example, if a patient believe we are selling their information or funneling their information or their secret to big tech or big medical companies or insurers, they will stop telling us the truth. Now, this compromise or this problem will compromise the care or the patient care immediately. So we must be transparent. We use data to save lives, not to sell ads, right? So our ethical obligation extend beyond the clinical wall to the database server. Imagine, for example, there is an app where a patient gets a notification that this Dr. X wants to use your blood work for diabetes study. And then the patient have a final say whether this blood can be utilized for this study or not. So if we have this kind of dynamic consent system, it will treat the patient as a partner, not a subject. So it will also increase the engagement and it will actually improve the retention in long-term studies. Technical solution, this was ethical solution, you can say. The technical solution to this one will be that how do we solve the problem of privacy versus research? So one solution to this can be that we stop moving the data. That means instead of sending the data to the AI company, which is developing AI model, we bring the model to the data. That means it's called as federated learning. The concept is known as federated learning. So we send the mathematical model to the hospital server, and then the model learns from the server locally. So that means the trained model will stay in that hospital only, and it will not be going back to the you can say the organization. So in this case, the patient record will be, for example, uh, will be confidential and it will be private. And then now when the model has learned the pattern, then this developed model, it can sit in a multi-center, for example, for collaboration. Okay. Any questions? Algorithm. Oh, what do you know about algorithm? What is algorithm? Anyone? Hello. Am I audible?
Yes, sir.
Okay, so what do you know about algorithm? Combines data, applies mathematics. Okay, that's good. That's good. Okay, anything else? Okay, so Nivedita, actually, this is one good answer, I can say. But when we say algorithm, and actually why we are calling it as a black box problem here, because we are mainly this black box is only applicable on term only for specific areas, not everywhere. So like for example, Pravina said it's like some set of rules that need to be followed. So that is also true. Generally, algorithm is a set of rules which the computer follows to solve a particular problem, right? So in general, when we are developing any algorithm, so we can understand that how the data is being processed. For example, let's say when you sort some, you use Microsoft Excel or something like that, right? And there you can sort the data from largest number to the smallest number, or like you have a list of names, you want to sort them alphabetically, right? So it is possible in Excel, you can just put them all the names in a row, in different rows, and then just click the sort button. So what will happen here, that the algorithm, that means when you are clicking the button, you are actually utilizing one algorithm which is taking this data as an input, and then it is rotating that and putting them, organizing them into a sorted order, alphabetical order. But when we move towards the neural network, there is a concept as neural network, not neural network, artificial neural network. In computers, they try to create a replica of human brains in the form of calculation, not actual human brain, in the form of calculation. So just like the neurons in our brain, they for creating memories and for solving any problem, how they interact. So they try to replicate the similar kind of process, not exact, similar kind of process in computers. So now they created, like for example, like thousands of these small nodes, and then the result from there, those nodes, they are transferred onto another layer. They are call it like multi-layer. So one layer, then the next, then the next. So information is processed in one layer. All the neurons, they interact with each other, and then they calculate the information, whatever they understand. They transfer that information to the next, then the next, then the next. But all this information here, it is happening in a black box. That means we don't know, even as a computer scientist, let's say, for example, even if you are expert in computer science, you know everything about algorithm and CA, you cannot actually tell that what type of processing or what type of mathematical function this finally neural network has learned, what variable it got, or what value it is transferring between different neurons. Okay, so we are not sure about that. So that's why what is going on inside the neural network, it is unknown to us. So that's why we are calling it a box, and because it is unknown to us, so that's why we are calling it as a black. So we are calling it as a black box because we don't know what's going on. But as such, if we just talk about algorithm in journals, they are not black box. We know how the information is being processing. So when we are talking about especially machine learning, and in machine learning, when we are talking about deep learning. So deep learning models, they often cannot explain why they reach a specific conclusion. Okay, so learning models, they identify patterns which are very complex for the human brains, but they cannot actually explain that. So there's a lack of explanatory power there. So if an like for example, when again come back to the software purchasing part. So if an AI denies an insurance claim or suggests a risky surgery, for example, it cannot explain why can we ethically follow that recommendation. So as a clinicians, I think you must demand explainable AI when someone is coming to sell you any AI solution. So you should say that we need a solution which is explainable. That means which is also explaining the reason as well. The network cracked for a moment and I missed your point. May I request you to repeat that black box means once you're free? Okay. Okay, so we are still on the same point actually. So what I was saying, that in general, in computer science, when we say algorithm, they are not black box, because in those algorithms we can explain how the data is transferring from one place to another place and how they are actually working, because it's just a set of rules, as you said. But when we are talking about artificial intelligence, so in machine learning, we use a concept called as artificial neural network. Okay. And then when we move into deep learning, so deep learning is actually, you can say, combination or different architecture or structure made from those neural network, artificial neural network. And what type of processing goes inside those neural network, we are not able to explain, or the computer is not able to explain that what type of processing is happening there. So that's why, because it's kind of a box in which there's some task is going on, but we are not sure what how it is coming to a conclusion. So that's why we are calling it as a black box. I hope that clears your doubt. Okay, so what is artificial intelligence? We have heard a lot about artificial intelligence, but it's not that old. Of course, the computers are not that old. So it has around 70 years of history behind it. But like when AI started in the beginning, there was very hype that it will solve everything. But then there was a gap around 20 years. Nobody talked about AI that much because there were not good computing powers available, and then we were not able to solve problem using AI. But then later on, then it is restarted developing, and especially in the last, at least if I say in the last decade, like I think around 2010, 20, after 2010, actually, the AI implementation become too much in everything. The main reason for that is we now have the computing power. We have smart computers, or you can say the power enough computers that can solve large amount of data, or that can process large amount of data. So what actually AI is, it just try to learn some mathematical problem. Okay, so if a problem can be fully solved mathematically, you can solve that problem using artificial intelligence. If a problem cannot be solved mathematically 100%, that means that you will not be able to solve it using AI. So for example, let's say there's a lot of buzz around this one, that whether AI will take your job or not. So just think about this. For example, let's say I'll talk about electrician, for example, or a plumber. So for a computer to calculate what a plumber does is, how do I store the data for AI integration? Okay, I'll discuss this just after discussing this. Okay, I'll come back to this. So for example, let's say we are talking about a plumber. So mathematically, to define that how does a plumber work, is not that possible. It's not easy, or it's not possible. So that means AI is not going to take that job. So anything. So there are two things for AI which it can do. First, there is enough data available from which it can learn the pattern. So the data becomes the most important part. Then second thing, that data, there is a chances that it can be mathematically explained. That means, like for example, when we are talk like natural language, when I was doing my research at that time, we used to think, or like most of the research paper which I read, almost every expert was in the view that statistical machine translation will not be able to translate the language because we had so much data, and creating the probability of identifying that which word will come after this word in a sentence using probability, at that time we thought that it is not possible. But then come, like for example, after some time, we got more, the computers were more capable of handling more amount of data. So now calculating the, if you list hundred thousands or thousands of documents, and so almost I think you will be able to identify the, okay, these words are always coming together. So there is a probability that if you are writing this word, what will be the probability of the next word? So you can easily calculate the probabilities. So most of the time when we are using nowadays these chat softwares like Chat GPT, Gemini, or any machine translation software, they are developed using statistical modeling, because we are able to using some of algorithms where we were able to identify that, okay, this probabilistic model can work in this environment. So same thing for artificial intelligence in any area. If that problem can be solved mathematically, and if the data is enough data is available in that field, so that we can do automate using artificial intelligence. And of course, we need expert knowledge as well of the behavior. Okay, so now coming back to your question, so I'm going to develop a disease prediction predicted through risk factor analysis. How do I store the data for AI integration? Okay, so now what is I don't know the word risk factor analysis, what it is. Okay, so just tell me, what type of data do you have? Deepak, are you here? Is this data for example, numeric format or image format? Numerical data. Okay, so here is now it's a numerical data. So in that case, what you have to do, the data will have multiple parameters, right? And in the end, based upon that parameters, like for example, you have to build cases that if this is the combination of the data, of course, like you will be having the outcome of this. Like for example, for any patient, you have those parameters, and in the end, you know the result whether it is uh, this disease is there or not, right? And if you have that, yeah, so if you have this, then it will be simple classification model. Okay, so you can utilize any classification algorithm, and you will be good. I hope that helps. So how can we use this for disease modeling? Yes, of course, we can use it. So again, what I'm telling, that when we are using artificial intelligence, we have to focus only on two things. First, what type of data we have. We have to understand the type of data. First of all, the data should, if the data is structured, much better, because structured data is easy to using structured data is easy to develop any neural network. Then the second thing is whether we are using numeric data or image data. So if it is numeric data, much easier task. If it is image data, we still have, for image data as well, we have to do some pre-processing for the images, like for example, maybe fixing the size and or removing some extras information, or so we can do, we have to do some pre-processing, but still, if it's still image data, it's also easy to do the processing and develop AI model. That just you need more computing power when you have image data, because image require large capacity computer. And that's why utilizing GPU or is much preferred when you are developing a AI model using images. Then the third is unstructured data. So for the unstructured data, currently it is difficult for like utilizing the unstructured, like clinical notes or something like that. It is difficult to develop the model, but if you have some expertise in programming or coding, what you can do, you can utilize the concept of large language model. There are many large language models. You can use them in your programs or in your application. And from the unstructured data like clinical notes, you can identify or extract the information from there, and then utilizing that extracted information, you can develop AI model for classification or regression, whatever task you want to do. So it's not, it doesn't matter what type of problem you are trying to solve. You have to focus on the type of data you have. First, identify the type of data. Second thing, clean that data. Data should be in proper format for whatever type of model you are going to do. And then identify that what I have to do, in which category you can put this data. Structured, if it is structured, whether it is numeric or it is text data or it is image data, and based upon that, you have to select the algorithm, that which algorithm will be more suitable in this environment. Okay. Like for example, usually our if our task is just to identify that this person has cancer or not, for example, or has this disease or not. So if this, like, it's a kind of classification, like for example, this is apple, this is strawberry, or like this. So in these things we are just trying to do very clear classification. Then second thing is prediction. This is also prediction. Second thing is like time series analysis, we call that. And that is like based upon the historical data, we try to predict whether this person will have this disease after 5 years or after 10 years or after 1 year or 6 months, like that. Okay. So this becomes the classification problem, sorry, regression problem. So there you can utilize any maybe time series class regression technique, or even there are neural network as well. So depending upon the data again. Okay, so AI and healthcare. So of course, we already discussed this part using these example that AI can be useful in healthcare in many different ways. It can have positive and negative, both impact it can have, and it can be utilized for prediction. It can be utilized for detecting the disease. It can also, like for example, nowadays telehealth and virtual healthcare, they are becoming very popular nowadays, and there are many software which are emerging to do like telehealth or virtual care. Okay. And the next topic is problem statement. This is again related to that COVID-19. Is like how COVID-19 affected the utilization of AI in healthcare. So there have been very positive impact, you can say, because after COVID-19, almost every country, they've pushed on the focus that you should digitize your health data, and you should create initiatives in which their e-health can be provided. For example, utilizing the internet for like for patient care or for providing diagnosis and other solutions. Okay. Then, when we want to utilize AI, especially in healthcare, so we require competency in AI. So competency requires integrating knowledge, skills, values, attitudes across multiple performance domains, and it must be continually developed in the current environment, in the face of rapidly changing or evolving technology. There are three main stakeholder groups which are impacted by AI in healthcare. First is, of course, the healthcare community, the people who provide healthcare. Then the health information technology solution developers, that means the companies or organizations which develop healthcare products like X-ray machines and CT scan machine, all those kind of any kind of healthcare products, or even the tools which help in assisted medical tools. Okay. And then of course in the end users also, they are like consumers or the patient, they are also always affected by the any change the first two community is going to do, so the end user will always be affected. Predictive analytics and decision support. So AI predicts, using AI, you can predict the risk. Like, for example, readmission is for a particular patient, or deterioration in their condition, or disease onset. So using AI, you can predict all these things in advance, and it can be helpful if you have the personal medical history of a person. So using AI, you can develop AI models which can guide them, or which can navigate their health care throughout their life, and then they can they will kind of know in advance if something is going to happen based upon their current condition, so they can take the precaution because they have been alerted using AI tools. So they can AI can provide real-time alerts, and in of course, like, you can develop clinical dashboards as well, where you can monitor maybe your patient continuously if you want. Okay. Then AI can also help in documentation as well. So all the nursing part and other document administrative part, they can reduce clinical workload as well with like with the help of AI. You can generate notes. You can just provide the keywords, and then the AI model will generate the complete note and the summaries. And then they can also improve the efficiency and uh, if like the physician has more time, so then they will have more time with the patient as well. So more face-to-face time we can develop. But again, the challenge still remains interoperability and contextual accuracy of the data. On governance and ethics barriers, so we are going to discuss this in details now. Ethics in clinical research. So first of all, what is ethics? Anyone? What is ethics? Does ethic means emotion or religion or law, culture, science? Do no harm, what is right and what is wrong, right? So ethics is not emotion. Emotion can influence your decision, and they may sometimes lead us away from doing what is right, as you said, and what is wrong. So especially if the right choice is difficult, so emotion can govern right, the rules govern right practice. Okay. So, ethics is not emotion, religion, law, culture, or science. Okay. So, let's discuss that. What are the main component of ethics? Okay. So, ethics, if we say like formally, if we try to define ethics in the form of definition, so ethics is the formal study of morality from different perspectives. Like, for example, in healthcare, ethical decision making is guided by four key principles: autonomy, then beneficence, non-maleficence, and justice. These principles they serve as the foundation for ethical practice and patient care. What does it mean actually? So autonomy refers to an individual's right to make their own decision. Then beneficence means it goes beyond avoiding the harm to the patient. It involves actively doing what is best for another person. So, as you said, Nivedita, do no harm. Then, non maleficence is the commitment to not cause harm and to prevent intentional harm as well. Okay. Then, justice, it relates to ensuring fairness and addressing what a community or a person rightfully deserve. There are five sources of ethical standards. The first I can call is utilitarian approach, which focus on the outcomes, aiming to choose actions that produce the most good and least harm. Then rights approach is the grounded in the belief that we must respect the inherent rights of others. Then the fairness or justice approach, it emphasizes treating everyone equally unless there is a valid and ethical reason to treat someone differently. Then the common good approach, it highlights the interconnectedness of all people and encourages actions that promote respect and compassion, especially for the vulnerable people. Then the virtue approach is suggests that ethical decisions should be guided by universal virtues such as honesty, fairness, courage, compassion, and prudence. So, ethical decision making framework serves as a valuable guide to help navigate difficult decisions. Uh, it is designed as a tool to use when facing ethical situation. So before taking any action, it is important to consult with your manager or supervisor and ensure you are familiar with the organizational policies. So, like for example, you have to you can this is just one example framework. I created this. Uh, no, I did not. I have taken this. I did not create this. I taken this from one of the research center for applied ethics. Okay, so all this ethics section I have sourced it from another sources, so I don't think that I have written anything from myself here. Okay, so any ethical system, healthcare system upholds a certain standard, for example, respecting the rights and dignity and safety of the patient. So this involves showing respectful attitudes and treating patient as the individual of worth. For example, helping patient understand their care and respecting their preferences for involving family and friends. Then respecting clinical judgments. So clinicians' judgment reflect their belief on the best course of action for a patient. So they should be informed by professional experience, scientific evidence, and the patient's value. Uh, but if there is an uncertainty in the clinical judgment or there are limited evidence, the weight of the judgment must be lessened on the patient, and patient should be informed about this. Then providing optimal care. So, like ethical care requires assessing whether the expected clinical benefits of an action outweighs the benefits of the patient would have experienced without having any intervention. Then avoiding unnecessary risk and burdens on patient. Uh, it means like ethical decision making, it should involve weighing the risk and burdens of an action against its potential benefit on the patient. Then understanding and addressing the health inequalities. So if patient navigators, for example, must ensure their action do not uh, perpetuate the patient to do something. Okay, then same thing for other as well, like understanding the health inequalities, then uh, conduct continuous learning activities that improve the quality of clinical care and healthcare system, contribute to the common purpose of improving the quality and value of clinical care and healthcare system. Evaluating the behavior. To stay within the professional boundaries, it is important to consistently evaluate our behavior. So before taking any action, remember that the patients view you as a representative of both of your organization and your profession as well. So, like when you are dealing with them, so consider some questions. Like, for example, what are my intentions, and how might the patient perceive this intention, or how might the other people will perceive this intention? And then another question can be like, whose needs am I meeting? Is this aligned with the expectations patient have of a healthcare team member currently? Or not, then what are the likely consequences of any action, both intended and pursued? Then how will this affect patients, their family, other patients, or colleagues? Then we also consider that do we have any biasness? So it can be implicit or explicit as well. That means the same process that make people smart can also make them biased as well. So this tendency for stereotyping, confirming thought to pass spontaneously through our minds is called as implicit bias. So it set people to overgeneralize sometime. Like for example, we can say that okay, there's this kind of people, the people who are not very rich, so they don't care about their health. So for example, if we can overgeneralize anything, we should never do that part. And because if we are doing that, then we're also creating discrimination among the people as well. So implicit bias comes from unconscious and unintentional association, and it results in both favorable and unfavorable judgments of the people or the patients. So it can be based upon your race, it can be based upon ethnicity, It can be based upon religion, gender, or other things. For example, let's say someone coming from my village or my hometown or my city or my country, I will be a little bit biased to them, right? I will try to favor them in some things. So it can happen, but especially in a field like medical field, so we should be very much careful about implicit bias. Then the last thing I think, or not the last thing, but one of the important thing is to always, as a medical professional, we have to make sure whether we are maintaining a professional relationship or not. Like for example, we have to evaluate that whether my decision will uphold the standard of the conduct expected by the employer, by the hospital, or by my profession as well. Clinical research. So in clinical research, it ensures the integrity of the research results, protect the ethical standard we are talking about. So in ethics, like we have to ensure the integrity of the research result, protect the safety of the patient who wanted to participate in the trials, then prevents participants from being exploited or treated unfairly by the research team, then foster transparency and accountability, allow for scrutiny and validation of research methods and research results. Issues with the clinical trials. Uh, there's a possibility that participations in clinical trials entails to an increased level of risk with respect to the ordinary clinical care due to the potential for exposure to unexpected effect of a new treatments. So we have to always weigh the benefit ratio, risk and benefit ratio, and we have to balance that. So sometimes the risk of a trial outweighs the benefit. So if as a clinician you see that the risk is higher, then you should uh, be more clear about this to the patient as a ethical or ethics research for your trial. You should make sure that the patient knows everything before he actually goes into the trial. So for the research that involves more than minimal risk of harm to participant, so the investigator must assure that the amount of benefit clearly outweighs the amount of risk. It is only if there is a favorable risk benefit ratio, then the study should be continued or it will be considered as ethical. There are 5 points which are necessary for planned and well-run good clinical trial. First is scientifically sound design that answer to relevant questions. We'll discuss what is scientifically sound design. The next slide. Then respecting the rights and well-being of the participants, be collaborative and transparent, feasible design for the context and managing the trial quality effectively and efficiently. So what is scientifically sound design? So when we say scientifically sound design, it should be robust randomization process, blinding or masking wherever feasible, then selection of appropriate trial population, then your sample size should be sufficient with the appropriate statistical analysis and statistical result. Then you should also adhere to the participant to allocate intervention. Then completed duration of follow-up regardless of whether a participant continues to receive the allocated intervention or ceases. Means you have till you design you want this study to complete, you should always be in their touch. Then measurement of the outcome should be relevant and simple as possible. More detail about this one, that the data collection which you are doing for this type of analysis, you should focus on the key aspect needed for assessment and should not be excessive. The approach which you are used to assess the outcome should be the same regardless of the assigned intervention. Then statistical analysis should follow the initial plan and the protocol which you did in the first step. then the potential harms of the intervention should be considered alongside the potential benefits, so risk and benefit ratio, and in the wider clinical health context. And then there should be an independent data monitoring committee to evaluate safety and efficacy of data from ongoing trial. This is what actually we try to in our organization. We mainly we don't do clinical research, of course, but we sometimes we have where there are human participants in the research. So we have this set of procedures that there should be one independent monitoring committee if there are human participants. So they will be evaluating the safety and efficacy of the data which is coming from those human participants. So that means the researcher will not be able to misuse their data. So I think every organization should have this kind of process if they are doing any kind of like clinical trials or something like that. So there should be a proper process for doing this. Health Insurance Portability and Accountability Act. I think, uh, are you aware about this? I think most of you will be aware. You are healthcare professional, of course. This is commonly used in United States. So we are not going too much into detail, but I'll just provide very brief information about this act. So this act was created in 1996, and it was mainly to protect the patient privacy, because in past there has been some misuse of the patient information. So the United States of America government, they thought to create an act which will help the patient to keep their information private. Okay, so like for example, they put that what information should be kept private or what information should be can be shared. So they create different kind of rule, and then against those, if someone is not following those rules, then there will be legal action taken against those. So for example, some of the entities which they said that they will be subject to HIPAA regulations, like health plans, healthcare clearing houses, then healthcare teams who transmit claims in electronic forms, or Medicare prescription drug card sponsors. So all these things, they are subject to HIPAA regulations. And that means that what does it mean that they are subject to? That means they cannot share the patient's information. Okay. Then the people who can share the information, so they are not required to follow the HIPAA regulation. For example, employers, life insurance companies, workers' compensation carriers, and school districts, state agencies, all these people. So they are not required to follow these regulations. So it is important for them to verify if the organization they are working, they are subject to same thing for I think applicable for you as well. I don't know which standard is being used in India. So whatever standard is being used in India or whatever act, so we should make sure that we are following those regulation or not. Some examples I have for the breaches of which happened in the past, which uh, there have been serious consequences of these breaches as well. Like for example, there was a health system which accidentally or unintentionally posted the thousands of patients' medical record online, exposing the sensitive information. Then there was a pharmacy which resold a used computer without properly wiping the data from the computer. So that means there it was recording the information about the patient and what medicine they have given to them. So they thought they just deleted one time. And they thought that the data has been cleaned from the computer, but they did not make sure. So now what happened that when someone purchased that computer, so they were able to recover all the information or all the patient's data, and then they start misusing that. Then there was a county health board member who worked as a banker as well. So he accessed the health record to identify cancer patients and then place the notice on their mortgages. So he also misused. So there have been many cases which like kind of given or being breaches in this regulation in the United States. So same thing can happen in any country. So just let's have some example that according to are you aware about this regulation, right? Hello, am I audible?
Yes, sir.
So the question is, are you aware about this regulation? I think all the healthcare professional they will be, because this slide is just if you are aware, then we can start discussing this. It is just uh, if you are aware, so we can say we can discuss these points. No, no one. Okay, okay then. That's it for today from my side. Thank you very much for being fantastic audience, being interactive, and now if you have any questions.
Participants, any query? So as there's no any query, so thank you so much, sir, for this very informative sessions. And as we know that AI is the need of modern healthcare, but while incorporating all those things into our healthcare setup, so what are the challenges we are going to face, and what are the important things we keep in mind while incorporating all those things, especially the data types and accuracy and completeness and the consistency of data incorporation, sensor data, data overload, and the challenges like signaling processing. So every aspects we are going to complete it through this session, the myths and ethics, ethical domains of the session. So definitely this session is going to be beneficial for all of us. And the session is so informative that this extended beyond the scheduled time from the participants as well and from the sir it's well. So thank you so much, sir.
Thank you very much for your kind words. Let me answer this question. There is a question, what is large language models? So a large language model, they are again artificial intelligence model which utilize natural languages. Natural languages means like the language English. Uh, Currently, most of the large language model they are in English. Okay, but there are some in other languages as well. Like for example, there's a few available in Arabic as well. So large language model, all the AI chatbots nowadays you see, whether it is Chat GPT, whether it is Google Gemini or some from other providers. So all those software or all those services are actually large language models. So what they do, why we are calling them as large, because they have large amount of language data on which these model has been trained. Like so, this is one thing. The second thing is the number of parameters. We are calling them large because mainly the number of parameters they have. So some of those models or model actually they are neural network models. So some of them had millions of parameters as well. So like few or 5 millions, 10 millions parameters. Because of the number of parameters in those models is too many, so that's why we are calling them as large language models. So this is one of the reason we are calling them large language model. And all the chat models which you are using nowadays, they are large language models. ChatGPT, Google Gemini, and others. Any other questions? Okay, so thank you very much, everyone. And if you need, you have any further question, please
Yeah,
you
thank you.
can contact the organizers and get back to you.
Okay, thank you so much, sir.
Thank you. So
So
I can
thank you
leave
so
now.
much, participants. Yes, sir. Thank you, sir. So thank you so much,
Thank
participants,
you.
for joining today's session. And thank you, sir. So as the session is continued for 9 more days, so we are looking forward to join you all for the tomorrow session as well. So thank you so much and stay connected for the tomorrow
Sure.
session.
Thank you.
Thank you.